Hello dear friends and my fellow pediatricians. Today I'll be presenting to you 5 case scenarios on allergy, asthma and immunology as part of the Unified Airway Disease System. Of these 5 cases, 4 cases were presented at the Delhi Pedicon to a panel of international and national experts. So I have the opinion which I will be sharing with you all. This article of mine on recent advances in pediatrics, a child with allergy, is a state-of-the-art article of 23 pages which covers all aspects of allergy. It clears the concepts and misconceptions about allergy. I would request you to go through this article. For those who need a soft copy of this is my website www.allergy.com. You can go onto this website and access my article on the child with allergy. Now, first let us clear certain concepts about allergy. Basic concepts. What does allergy refer to? It refers to a hypersensitivity reaction. What type of hypersensitivity reaction is a type 1 hypersensitivity reaction that occurs upon re-exposure? The word re-exposure is very important because the patient comes to you with a rash and you ask him, have you eaten this so-and-so particular item? And he says, I ate this thing before and nothing happened. And that is the key on re-exposure to a sensitizing allergens. So can you be allergic to smokes, perfumes and deodorants? The universal answer and a unanimous answer would be yes. But the emphatic and the categorical answer is no, you are not allergic to smokes, perfumes and deodorants. They are all chemical substances. You are allergic to a living molecule, to a protein molecule such as dust mites, fungi and pollens, causing the release of inflammatory mediators. It's a whole cascade which I'll be explaining to you subsequently. Well, atopy is a genetic state of a person developing either allergic rhinitis or atopic dermatitis or asthma, either all at the same time or one at a time or maybe none at any time. But when I refer him or label him as atopic, it means he has a genetic tendency to develop. If he is non-atopic, then it is very unlikely that he will develop any of these. So it is very essential, especially based on the family history, to identify whether the person is atopic or non-atopic. Now, what is the natural history of allergic diseases in an atopic child? It usually presents the GI manifestations in the first 6 months of life, and as the GI manifestations are coming down, the skin manifestations start peaking at 1 year of age, and as the skin manifestations are gradually coming down, the wheezing starts and will stabilize at around 3 years of age. And around this time, the allergic rhinitis gradually starts increasing into adolescence and adulthood. So it may happen that you may have a child who is 7 years old and you may have diagnosed as allergic rhinitis. And if you go into a detailed history, the mother may give, but not necessarily always will give, that when he was a child and an infant, he used to bring up milk very often. He was a very colicky type of baby. Then subsequently he developed rashes, which disappeared. And then around 1 to 2 years of age, he used to wheeze a lot and my doctor cured him of it. The truth is, his doctor never cured him of it. It is that one form has replaced another form. Now, I will go through 4 slides on the basic immunology of allergy. If you understand these 4 slides, you will understand the entire clinical diagnosis, the management of allergies. And this applies to all, whether the skin, the GI tract, the lungs, or the nose. So over here, we'll deal with the nose as the focal point. So when your allergen comes in, what is the defense mechanism that you have? You have 3 lines of defense. The first line of defense consists of the epithelial cells, the dendritic cells, and the goblet cells. The second line of defense consists of the T lymphocytes and the B lymphocytes. And the third line of defense consists of the mast cell, the eosinophils, and the neutrophils and basophils. So now when your protein molecule or your allergen, which enters your nose, once it crosses the anatomical barrier, it has to swim across a river. What is the river produced by? It's a river of mucus produced by the goblet cells. Once it's able to swim across, it has to jump over a wall. What is this wall made up of? The epithelial cells. Once it jumps over the epithelial cells, it is encountered by the dendritic cells. What does the dendritic cell do? It only behaves like as a immigration officer. So he'll recognize whether you're foreign or you're native. The moment he recognizes that this particular allergen is foreign, he will immediately shake hands with him and take him to his boss. Who's the boss? The boss is the T lymphocytes situated in the adjacent draining lymph nodes, and that's why you get this non-specific lymphadenitis. Now, what do the T lymphocytes do? The T lymphocyte is the director of the entire immune system. So the T lymphocytes, on encountering this allergen, will start sending signals to the circulating B lymphocytes. And how are these signals sent? The signals are sent in the form of chemokines and cytokines. So what do the circulating B lymphocytes do? They start producing arms and armaments which are required to deal with foreign allergen. So what is these arms and armaments? They are nothing but IgE antibodies specific to that particular allergen. So once your arms and armaments, or that is your IgE antibodies, are produced, ultimately you require soldiers to deal with this foreign enemy, to carry these arms and armaments to the site of action. And who are the soldiers? They are the mast cells. The mast cells will carry on the shoulders. They'll move from the subepithelial area of the nose to the epithelial area. And this is how it occurs. Once your allergen has come in, it's in response to the allergen, the IgE antibodies are produced, and these IgE antibodies specific to that particular allergen go and sit on top of the mast cell. There may be millions of such of IgE antibodies sitting on top of a mast cell. So at this stage, what has happened? The mast cell has become sensitized. The patient has become sensitized. And any of us sitting in this room can be sensitized, and we may not have the signs and symptoms which you normally associate with allergy. Now what happens on re-exposure? On re-exposure, the allergen is caught up between the two arms of the IgE molecule. And when it is caught up between the two arms of the IgE antibody, it leads to the breakdown of the mast cell, causing a release of preformed mediators, the most important being histamine, and newly generated mediators, the most important being cysteine leukotrienes. And this leads to the symptoms of early phase reaction such as congestion, rhinorrhea, but the predominant symptom is pruritus and sneezing, and that's why they're known as runners. And this is the early phase response which occurs within minutes. Subsequently, at the same time, there's a release of chemotactic factors, and because of the release of the chemotactic factors, there's an infiltration of that particular area with cells such as basophils, eosinophils, monocytes and lymphocytes, leading to the symptoms of late phase reaction. The predominant symptom of the late phase reaction is congestion, and that's why they're known as blockers. Dust mites usually present as blockers. Pollens usually will present as runners, and this is the late phase response which occurs within 2 to 8 hours post challenge. So putting it all together, you have the allergen which has come in, which has caused the sensitization, the mast cell on repeat exposure. There is early phase reaction leading to histamine release and cysteine leukotriene release. At the same time, the release of chemotactic factors will lead to a cellular infiltration causing late phase reaction. So why do we have a late phase and an early phase? See, it takes at least 48 hours for the body histamine to get replenished. So the late phase reaction is a backup response. It is as strong as the early phase reaction, but slower in action. Now, what are the risk factors for allergic rhinitis? There are various risk factors such as small family size, which is mainly based on the hygiene hypothesis, early use of antibiotics, Western lifestyle, dietary factors, passive smoke exposure, atopic dermatitis, and high serum IgE levels at 6 years of age. But the most important factor is genes and environmental factors. So if you, for example, if your right hand is the gene and the left hand is the environmental factors. So if you have only one hand, it will be like this. But when you have both the hands, you get the impact and the disease. A classic example of this, when I was working at the Royal Manchester Children's Hospital in the United Kingdom, they had so many South Asian children, Indian, Pakistani, Bangladeshi, Sri Lankans, presenting with food allergies. How many cases of food allergies do you see out here? Hardly any. If any, if you would see, it would be more among the NRI children. So why is it that our children who have gone there were being brought up over there are suffering from food allergies, but not the children out here? It is only a matter of the change in the environment. The gene is there, but as soon as the environment will change, the food eating habits will change back in a country, you will very soon get an epidemic of food allergies. Now, with this we come to the first case scenario. Zaid, a 2.5-year-old male NRI from Australia, brought to a clinic for the complaint of a constant cold. बार-बार सर्दी होते रहती है इसको. Incidentally, while examining, the pediatrician noticed that the child was not interacting well. On examination, no significant finding. So what further would he do? He found that the child was suspected to have autism by his GP back in Australia. The speech was delayed, just only 3 to 4 words in a 2.5-year-old child, and there was snoring was also present. There were no associated symptoms. And we also noticed that the child was not much active with peers and was very restless at all the times. So what is a diagnosis and what would you do? An otoscope was attempted, but since the child was very restless, we could not appreciate the movement of the eardrum. As a PALS convener, in a PALS module, we teach our delegates that when you join medical college, the first thing you should buy is a stethoscope. When you join pediatric residency as a postgraduate, the first thing you should buy is an otoscope. And when you start practice, the first thing you should buy is a pulse oximeter, because with a pulse oximeter you can pick up an emergency within seconds. If you're not there in the clinic, your assistant, your nurse can pick up the emergency within seconds. So it is very essential that you should make it a point to look into the ears with an otoscope. And we also did tympanometry, which showed bilateral middle ear fusion. Tympanometry is a very good tool in diagnosis of middle ear fusion and to look for the state of the eustachian tube. It is present in almost every clinic in the United States of America. In the city of Hyderabad, the test costs 200 to 300 rupees. We also did X-ray nasopharynx, which showed moderate enlargement of the adenoids. So the diagnosis is bilateral middle ear fusion with adenoidal enlargement. Now what would be a diagnosis and how would you treat? This patient was given a 2-week course of intranasal mometasone plus montelukast plus clarithromycin was given. And repeat tympanometry showed no effusion. Child was more interactive and the restlessness had come down. So what further tests are required? So considering that this background of this child coming from Australia and there being no fever, we felt that this is very unlikely to be a bacterial infection. The clarithromycin need not have been given to this particular patient. All the patient required was an intranasal mometasone. And considering that it could be just either viral or allergic rhinitis, the home background suggested it was more an allergic rhinitis. So what we did was, we did the blood test for dust mites by immunocap method, and they showed for deep pharynx and D-terinosis, these are the two types of dust mites, they were positive, 68.70 and 52.70, they were very high. The normal is less than 0.01. So it is very strongly suggestive of allergic rhinitis. You need not do these tests in every case where you suspect allergic rhinitis. But if the detailed history suggests that there's a possibility of dust mites in those particular cases, then you can look for it, because the cost of each allergen is almost 800 to 900 rupees. The issues to be discussed in this case, whether you do a hearing test or not, yes, a hearing test is required. What about environment aeroallergen control? It's very, very, very essential. Whether you keep this patient on mometasone or mometasone plus montelukast or only montelukast, at this stage to decide which one should be is very difficult. We will make this decision as we treat the patient subsequently. But this patient being strongly a case of allergic rhinitis will either need one of these 3 treatment regimens. ENT opinion is required or not? No, it's not required, because there is a possibility that the ENT surgeon may subject the patient to a T adenectomy. What you can do is subject the patient to a medical adenectomy. What is a medical adenectomy? You give an intranasal course of steroids for 6 weeks to 8 weeks, and the whole adenoids will shrink. And the last and the most important thing, the possibility of the autistic spectrum disorder should always be kept at the back of the mind in this particular case. You cannot still rule it out. Now, with this, what is allergic rhinitis? Allergic rhinitis is a chronic inflammatory disease of the nose induced by an IgE-mediated inflammation. It is very essential that the key in allergic rhinitis is IgE. It has to be specific IgE. Total IgE has no meaning in the diagnosis of allergic rhinitis. You have to look for specific allergens, specific IgE. After allergen exposure of the mucous membrane of the nose, and the 4 major cardinal symptoms consist of snoring, itching, rhinorrhea, and congestion. AR is more than a simple sneeze. You're not sitting over there watching me speak on just a sneeze. You are here to listen to a disease which causes problems in the context of systemic allergic disease. And this is a whole range of symptoms. It can cause cough, sneezing, nasal pruritus, nasal congestion, sore throat. They can just present as recurrent infections, respiratory distress in an infant, hypernasality, and behavioral problems. Behavioral problems, as our particular case had, Zaid, he presented with behavioral problems. Halitosis, any patient coming with bad breath, think of allergic rhinitis. But it's the comorbid disorders which are really of concern, such as conjunctivitis, pharyngitis, sinusitis, asthma, eczema, otitis media, lymphoid hypertrophy. You have those patients coming with non-specific lymphadenitis, you may be prescribing Ceftriaxone or some other drug like that. Think of allergic rhinitis in those particular patients. Speech impairment, this particular patient had. Failure to thrive and reduce quality of life. Just 3 letters, QOL, quality of life. The West is spending billions of dollars. Why? This is one of my presentation at an international congress. This is what the US spends, $5.5 billion only on the management of allergic rhinitis. And this is what the government of India spends, okay? Only its health budget. This is the expenditure of the entire country on both asthma and allergic rhinitis. So why is the West spending so much only on the management of allergic rhinitis? Only because of 3 letters, QOL, quality of life. In India, you can snore and get away with your spouse. You can, in a public place, you can do without any financial or without any social consequences. But in the West, in US, there's a lot of pressure to look good, feel good, and smell good. In India, the pressure is there, but it is only time bound. For example, a mother will get her 18-year-old daughter to me and say, well, she's the whole night, she's snoring, she keeps doing like this, clearing her throat. Doctor Saab, kuch kar do iska. So for 6 months before marriage and for 6 months after marriage, she will be regularly coming to me, getting every possible treatment done, every possible investigation. Monetary constraints are not at all over there. But 6 months after the marriage, she has become well, settled into a new family, is out of sight, out of mind. But things will change very soon. So what is the clinical presentation of allergic rhinitis? It consists of 4 major symptoms such as sneezing, very easy to diagnose, itching. The patient knows my nose itches. You have to ask a leading question. You keep doing like this. Rhinitis, very easy to diagnose. And congestion. The patient wants to say my nose is blocked. You have to ask whether you keep clearing the throat or not, whether your ears get blocked or not. So is any one of them allergic rhinitis? No. If 2 or more of these are present for more than an hour or most of the days, then only you think of allergic rhinitis. And this last line is very important. 2 or more of the symptoms for more than an hour on most of the days is allergic rhinitis. So the diagnosis of allergic rhinitis is purely clinical. There are no tests to label this patient as allergic rhinitis. Now we come to the second case, which you all commonly see in your outpatient. Sonali, 5-year-old female child, history of repeated wheezing. Each episode of this wheeze has been preceded by a cold which may consist of a nasal itch and a runny nose and may or may not be accompanied with low-grade fever. And every time it is relieved with a course of antibiotics, montelukast, antihistaminics and nebulization. Tell me, is this not a common case scenario? This, everything possible that you have in a clinic is thrown at the patient. And he'll be going round and round and round and round to all the doctors, and every time this is the standard treatment. So now he has come to you and for a final diagnosis. So what we find, what you have to do is to first differentiate whether it is a common cold or allergic rhinitis. A common cold lasts for a week, allergic rhinitis lasts for more than 10 days. Common cold equivocal response to antihistaminics because of most of the time you're giving first generation antihistaminics which have anticholinergic effects and will dry up the secretions. Well, there will be a good response to antihistaminics in a case of allergic rhinitis. Usually will have fever, no fever, have constitutional signs in common cold, will have allergic signs. Nasal mucosa is red with thick mucus in common cold. Nasal mucosa is pale boggy with thin mucus. Here many people will be in the family will have it in allergic rhinitis. Not many people will have the same acute symptoms in the family. So what is the further line of approach? We found that the cough was at times of episodes of lying down at night. This is a very important aspect of the history. Family history and drug allergy is nil. Father smokes but not in presence of the family. Snoring and mouth breathing is there. Examination is normal. X-ray shows adenoids. So what is the diagnosis and how would you treat? So before I ask you that what is your diagnosis, let me put the patient's perspective to you as to why he has come to you basically. He has only one question. Is this asthma or will it go away or not? That's all. He's so fed up that he wants his answer and whether it will ever go away. And you have to give an answer. So let's see how we can do it. So if you see this, I'll help you out. The first and foremost thing, if you look at it, the cough is at times of episode of lying down at night. The cough of asthma usually will be after midnight, early morning. That's an important thing. Second thing is a very, very essential thing that you have to look at, the family history. The family history is the single most important factor, whether the father, parents, or mother having allergic rhinitis, asthma, atopic dermatitis. The child has comorbid disorders such as atopic dermatitis. None are there. So this is a very essential thing in saying whether the child is having asthma or not. So father smokes, but the smoking could be one of the reasons also for the wheezing. The other, what Gina says, is the response to bronchodilators and the response to inhaled steroids. Now, in this particular case, since there is no history, you can safely tell the parents that your child is unlikely to develop asthma, and with age, this particular condition will go away. What we do sometimes when the patient wants any test to rule out atopy, skin testing or immunocap, looking for specific aeroallergens such as dust mites and fungi. And in this patient, the skin test was done, skin prick test, and it was normal. This doesn't mean to say that in all such cases you should do a skin prick test or look for immunocap. The single most important factor to differentiate is atopic or non-atopic is a history, and a good history. Now the next thing is, how do you manage this case? Who is non-atopic? What about montelukast? Yes, this patient needs to be on prophylactic montelukast. Oral antihistaminics, since it is non-allergic, antihistaminics have no role. Oral salbutamol, inhaled oral, only at the time of episodes. Oral salmeterol plus fluticasone budesonide prophylaxis, it is a severe type requiring hospitalization. What about the role of antibiotics? Since it is all viral-induced disease, you need not give antibiotics. We come to the third case. Jabin, 14-year-old female child, episode of repeated blocked nose and runny nose in the age of 6 years. So there is a blockage and there is running, both blocker and runner. What for the history? We find that there is no nasal itch and sneezing, repeated eye discharge and itching, no episodes of wheezing and no skin changes. Repeated episodes of headaches, sleeps at daytime and does miss schools. Family history of similar complaints nil. Examination average build, chest normal, ears wax, nasal bilateral congestion, sinuses, mild tenderness in maxillary area, and eyes are normal. So what is the diagnosis? So in this particular case, it's very obvious. The answer is allergic rhinosinusitis. Why do you say that? Repeated blocked nose and runny nose. Two things, blocker and runner. Both are there in this on most of the days, for more than on most of the days. So it is allergic rhinitis. At the same time, it has headache. So that's why you would say that allergic rhinosinusitis. But is that the complete diagnosis? No, that is not the complete diagnosis. To institute treatment, you have to make a complete diagnosis. And that's how this is to be done. Clinical classification or categorization of duration and severity. Is that intermittent or persistent? It is intermittent if it is less than 4 days per week or for less than 4 weeks per year. It is persistent if it is for more than 4 days per week or for more than 4 weeks per year. And it is mild if the quality of life is normal. It is moderate to severe if there is impairment, slightest impairment of the quality of life, such as abnormal sleep, impairment of daily activities, sport, leisure, abnormal work at school, and troublesome symptoms. So the number 4 is the key to the understanding of this classification strategy. So in this particular case, our patient, Jabin, what is she? We all know it is allergic rhinosinusitis, but we have to make a complete diagnosis. So what would it be? So since it is present on most of the days, it is persistent, moderate to severe. That's the diagnosis. Allergic rhinosinusitis, moderate to severe, persistent. Because then what would you need to give to this child? Whether you give antihistaminics, you give intranasal steroids alone, INS or montelukast. So you have to make blocks like this. Either mild intermittent, moderate severe intermittent, mild persistent or moderate severe persistent. The most important treatment in all the types that you have diagnosed is allergen irritant avoidance. Without allergen irritant avoidance, there cannot be complete relief. Allergen irritant avoidance will bring about 40 to 50% improvement in the condition, and then the pharmacotherapy will do the rest. So if you are giving only pharmacotherapy, mark my words, the patient will never be normal. So it is very essential that you be able to identify the allergen, the irritant, and try to remove the allergen or the irritant from the patient's environment. Then you have the intranasal steroids. Anything beyond mild intermittent, the most effective drug in the management is intranasal steroid. The very important thing is correct technique. Outwards, both sides should be outwards. It should never hit the medial wall or the septal wall. If the technique is correct and it will cause no complications and it will be very effective. If the technique is wrong, then it can lead to intranasal bleeds. So it is very essential that the technique is correct. And if it is severe type and all this is not enough, then one needs to go on to immunotherapy. So what is this allergen irritant avoidance? And it's very essential that you should know what is allergen irritant avoidance. So the triggers for allergic rhinitis, the aerobiological, the dust mites are there in more than 50% of the cases, the cockroach in 25%, fungi pollen in 7.5%, pets on 5%. While these are the only irritants which will only make the underlying allergy worse. The patient may come and tell you, I have allergy to perfumes. It's not that the patient has an allergy to perfume. There is an underlying allergic rhinitis to one of these aerobiological, and it is the perfume which is only worsening the underlying allergy. So it is for you to recognize which are these aerobiologicals. So how do you should know? You should have, for that you need to have a knowledge to what are the three important types of dust mites, what is the source of dust mites, is it carpets, draperies, upholstered furniture, the condition within which the dust mites will increase and decrease, and the avoidance measures. In short, if I put it in one line, I would tell them lower standard of living. What do you mean by lower standard of living? From upper class to a lower class. You get rid of all these carpets, these cuts and false ceilings, heavily upholstered furnitures and furry pets, furry toys, and those heavy curtains. This is what they have to do. The house should be simple with all things. There should be no clutter around. But it's very difficult to exercise, but that's what is the most essential thing, to keep dust mites away as much as possible. Next is pollens. Pollens can be tree pollens, grass pollens or wheat pollen depending on the time of the year. You should know the condition in which the pollen count will increase and the avoidance measures. To put it in one line, stay indoors with all doors and windows closed between 11 a.m. and 5 p.m. A difficult thing to do, but then that's the extreme measure that you can subject the patient to. And fungus are triggers of allergic rhinitis. The problem with fungus is, unlike pollens which are strictly outdoor and dust mites which are strictly indoors, fungus are present both outdoors and indoors. You should know the condition in which the spores will increase, the source of the fungus and the avoidance measures and the different types of fungi. In short, if you put in one line, as Shah Rukh Khan says, Nerolac paint lagao or kanjal bhagado. So you should have a newly well painted house, and there's very much unlikely that you will have fungus in such a house. Pets as triggers of allergic rhinitis. All warm-blooded animals are potentially capable of sensitizing susceptible patients with allergy. Is mainly from the saliva, urine, skin and dander. Allergy to dogs appears less than that to cats. Avoidance is the most effective way. Okay, but before you tell the parents or especially the child, an adolescent child, to remove the pet, be careful. They are more likely to throw you out of the practice rather than remove the pet, because pets often as stress busters. I mean, it's so sad. In my clinic, I just talked that the whole cause of your allergy is the pet, and the tears will just start flowing down. So you have to be very, very, very careful regarding pets. In fact, we can take a whole day presentation on the pet management. That is what has to be taught to the parents, how to manage the pet in that particular environment. And last, the cockroach, which is the significant cause of this nasal allergy. You should know what the source is and the avoidance measures. In one line, Pest Control of India. So in our case, Jabin, whom we have diagnosed as allergic rhinosinusitis, moderate to severe persistent, she's had a treatment with the combination of montelukast and levocetirizine and fluticasone OD on a daily basis since 9 months, and now her quality of life is better. She's able to attend school daily. So what would be a further line of approach? If the patient is happy with this particular line of approach, with this particular treatment, they can go on lifelong. But this patient was not happy. I mean, they couldn't go on taking the pharmacotherapy on a continuous basis. So we did the spirometry. We showed mild bronchial hyperresponsiveness. 35% of your AR will have an underlying asthma. 80% of your asthma will have an underlying allergic rhinitis. So always look for asthma in all patients of allergic rhinitis and vice versa. We did the skin test and it came positive for dust mites, and anything which is more than 3 mm is positive. So this patient was positive dust mites. We put on immunotherapy, and today this patient, because of immunotherapy, is off all pharmacotherapy. So this comes to the next thing is, how do you look for the allergens? You have the allergy blood test and you have the skin prick test, which have a high sensitivity, greater selection of antigen, available in minutes, less expensive with minimal equipment. And this is what the equipment looks like. These are the different aeroallergens. like dust mites, fungi, and pollens. This is how you do it. You place a drop of the allergen, you prick with a lancet, wait for 20 minutes, and if you see a wheal formation more than 3 millimeters, then it's likely to be positive. And this is how. This is negative, 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 negative. This is positive, but it is false positive. Why is it false positive? Because a dot of blood has come. No blood should come. If blood comes, it is false positive. It has to be repeated. Well, this is positive for dust mites. 3 types of dust mites, and it's positive. This is saline, which is negative, and this is histamine. The histamine should always come positive more than 3 millimeters because that is a control. And for that, the patient should be of first generation antihistaminics for at least 3 days and of second generation antihistaminics for at least 7 days. It is commonly done by the prick method. There are no known reported cases of anaphylaxis following a skin prick test method from anywhere. It demonstrates allergen-specific IgE. It correlates well with clinical history and challenge tests and a prerequisite for starting immunotherapy. Then there is also a prick-to-prick test. Now, any food item, whether vegetable or a fruit, which can be pricked with a lancet, you can test whether the patient is allergic to that particular food or item or not. So now here we have a brinjal instead of a banana. So what you do is break open the brinjal like this. Then this is the lancet. This is the lancet. You prick the lancet into the particular vegetable or fruit. Then you have circles drawn on your hand. And what you have to do is just lift the skin for 10 seconds and leave. I'll show it to you again. Just prick the skin and leave. Okay. So how to interpret it? If after 20 minutes it comes negative, then with almost 100% certainty, you can tell the parents that the child does not have any allergy to this particular food item. What it comes positive? If it is more than 3 millimeters, if there is blood, then it is false positive. If there is no blood, then there is only a 50% chance that the child is allergic to that particular food item. The ultimate test of the pudding is in the eating. So the child has to be subjected to a direct challenge with that particular type of food, of whether it's a fruit or a vegetable. To get respiratory manifestations secondary to food allergens without any GI manifestations or without any skin manifestations is very, very rare. Now, what is the clinical relevance? It gives the treatment options: allergen avoidance, the choice of pharmacotherapy, and immunotherapy. And special relevance in children, Sonali, the 5-year-old child, where you can subject this patient to a skin prick test, and if it comes negative, you can safely tell the parents that you do not have any allergy or any asthma. Now, what is allergy threshold? It's a very important question because a lot of people will ask me, how long do we give this intranasal steroids? How long do we give the treatment? How frequently we give the treatment? All depends on the allergy threshold. And that is the amount of allergen particles required to initiate an allergic response, varies from patient to patient, and within the same patient with time explains the variation in clinical symptoms. All of us sitting out here, when we are exposed to 20 micrograms of dust mite per gram of dust, we'll all start sneezing. So are we suffering from allergic rhinitis? No. A patient with allergic rhinitis will start sneezing to as low as 2 micrograms of dust mite per gram of dust. 2 micrograms. So by our pharmacotherapy, by a good environmental control, we are only raising the allergy threshold, which can vary in the same patient from time to time. And depending on his threshold, it will depend the time of duration that the patient will require the course of pharmacotherapy. So, are all the antigens that the patient is sensitized to clinically relevant? No, only those antigens that correlate clinically. So, clinical correlation is very, very essential. Many patients are sensitized to antigens, do not react with clinical expressions. Normal subjects also show sensitization. South Indians, rice eaters; North Indians, wheat eaters. South Indians, you subject them to, you test them for rice, they might come positive. So are they allergic to rice? No, they're only sensitized. They are not allergic. Only if they develop symptoms and exposure to rice or ingestion of rice, then only you will say they are allergic. And a good history and knowledge of local aerobe allergy is critical in judging clinical relevance. So you should test for pollens which are present in your environment, not for pollens which are present in the temperate countries such as cider, oak, pine, and so on. So the common pollens which are there in your particular area, such as Parthenium and so on, should be tested. With this, we come to the fourth case scenario. 12-year-old Nitesh Suresh had numerous episodes of acute brittle asthma. Episodes are sudden with rapid deterioration requiring hospitalization, presenting on 4 occasions with pneumonia in the last 7 years. The first were right basal in 2007, then in 2010, then 2012 and 2013. They were definite pneumonias, X-ray proved pneumonias, and occurring on both, not necessarily on only one lung, it was also on the other lung. Peak flows are stable, 240 to 280, can drop dramatically to 120 in acute episodes. Interval symptoms consist of nocturnal cough, chest tightening, exercise-induced wheezing. History of sniffing, allergic salute, and facial grimace is very important. Throat and nose itchy since the 5 years. History of mouth breathing and snoring since 5 years, and less in the last 2 years when intranasal steroids were started. So this is a very essential thing, and a very common mistake which we do. As you see in this case, there was the signs of allergic rhinitis were present in the last 5 years, but the patient has been given the treatment for allergic rhinitis, that is the intranasal steroid, only in the last 2 years. So my point which I want to bring out here is to diagnose allergic rhinitis as early as possible and start treatment for it. And by that way, you will decrease the symptoms of asthma in those particular patients who are suffering. Since January 2014, it's been well controlled. There's a family history of atopy. Mother is allergic rhinitis with atopic dermatitis and had mild persistent asthma, but is under treatment. So what is the diagnosis? You all agree it is severe persistent asthma with moderate severe persistent allergic rhinitis. There's no doubt about the diagnosis. How would you treat it? Spirometry, which showed moderate obstructive airway disease, but the patient was under treatment. Current treatment is fluticasone 250 plus salmeterol 25, 2 parts 2 times in a day. Montelukast 5 mg at bedtime, fexofenadine, intranasal mometasone, salbutamol up to 6 puffs plus ipratropium as relievers, home oxygen for emergency use, and prednisolone 40 mg for emergency use. So I would go with all this treatment, there's no doubt about it, but some people would question about giving fexofenadine in this particular case, where it is so severe that the physicians were giving almost everything possible. So, but basically fexofenadine is not actually required in this particular case. How do you explain the repeat pneumonias? So we did a full workup and lung CT scan was normal, X-ray chest was normal, immunological workup for repeat pneumonia was done, in which NBT test showed normal, IgG, IgM and IgA, and CD count were also normal. Complement CH50 was 23.5 with a normal of 51 to 150. Sweat chloride test was also normal, bronchoscopy was normal. CT scan of sinus or maxillary and ethmoid sinus showed mucosal thickening with maxillary polyp. What would you like to do for the investigation? So allergen testing is a very essential point. It starts with a good history. So we found that the symptoms were exacerbated on exposure to house dust, more in the monsoon winter. That's a time when the house dust mite concentration goes up. There was no change in symptoms on exposure to pets and birds. Total IgE was 510. Skin prick test showed positive for the 3 different types of dust mites, 6 mm, 7 mm, and it came positive for Aspergillus fumigatus 4 mm, but we did a specific IgE which was negative. So what further history would you ask? So all these are questions for discussion. How often do you see asthma with recurrent pneumonia? 20% of asthmas can have recurrent pneumonias. Every child of asthma getting recurrent pneumonia, would you just leave it at that 20% can get repeated pneumonia? No, if they are getting repeated pneumonias, one has to do an immunological workup. Should approved atopic asthma with allergic rhinitis be investigated for immunological workup? No, it's not required, unless and until the child is getting recurrent pneumonias. Should asthma with AR with polyps be investigated for cystic fibrosis? Polyps are part and parcel of cystic fibrosis in an adolescent. So, unless and until there are other complications, and asthma with AR with polyps need not be investigated for cystic fibrosis. What treatment options to consider? You see, this patient was being given the maximum dose of fluticasone, that is 1000 micrograms, and therefore we started this patient a slow release theophylline, unicontin, and after adding that to this particular line of therapy, the patient did much better and was able to have a normal life. Anti-IgE or omalizumab is a new line of treatment which is given in severe persistent asthma with underlying allergic rhinitis with IgE of more than 700. But for that, the child should be more than 12 years. What we give is injections of anti-IgE injections for at least or maybe required lifelong. Each injection is given every month, and each injection costs almost 15 to 16,000 rupees. But in the US and the West is very common way of treating these patients, because the insurance finds that easier to give this injection than admit those patients into ICU. But in India, there are a lot of patients which are being covered by insurance and by government agencies are taking this particular type of treatment. Role of prophylactic antibiotics is a divided opinion. How does my desensitization? I'll come to it subsequently. And should we carry emergency adrenaline with her? Yes. If you look at it, the earlier treatment for asthma was adrenaline. And this particular child, having an allergic background, should always be carrying emergency adrenaline with her. We come to the fifth case, Kush, 15-year-old male child, constant sneezing, especially at night time since 1 month. This blocked nose, sleeps and daily activities totally disturbed. Started on Montelukast plus antihistaminics plus mometasone, will improve only after the 14th day of treatment. Also started on alternative medicine on 10th day. Since then better and is on both allopathic and alternative medicine. And this is a very common case situation. Now the patient, you have started treatment, is not improving and they go for alternative medicine and they'll be taking your treatment, but maybe giving more credit to alternative medicine than to your allopathic medicine. You also notice that there was a history of constant headache 2 years back for more than a year, treated as migraine by the neurologist, since mom was also having migraine. We did a review of the CT scan was done, which was taken 2 years back, and we found there was maxillary sinusitis and nasal polyp. Now I'll play a video of this particular patient, the way the patient has been sneezing. What is the diagnosis? So obviously the diagnosis is nothing but allergic rhinosinusitis. How do you explain the improvement 14 days? It is very essential that you should prescribe the intranasal steroid for at least 14 days and tell them that the improvement will occur around 10 to 14 days, because that's what it can happen sometimes. Could the diagnosis of migraine made earlier be wrong? Yes, if you look at the case scenario now, what test would you do? You did a skin prick test, which is positive for all types of dust mites. So this is how it presented. It brings us to the last part of my lecture, initiating immunotherapy. When should you initiate immunotherapy? The most essential thing is you have to establish it is IgE-mediated disease. How do you establish it is IgE-mediated disease? Either by skin prick test or by a serum-specific IgE. Then there should be documentation of clinical sensitivity. That means if you have come positive for dust mites, on exposure to dust mites, you should show the particular symptoms of allergic rhinitis or sinusitis. Third thing, response to allergen avoidance and pharmacotherapy. Having come positive, having shown symptoms on exposure to that particular allergen, when the patient is removed from that particular allergen and subjected to pharmacotherapy, he should show an improvement. Next is the severity and duration of symptoms. The severity and duration of symptoms should be such to affect his quality of life. If it is affecting his quality of life, such as school absenteeism and work loss, then only the patient should be subjected to immunotherapy. Next is PFT. It's a very essential thing. The forced expiratory volume should be more than 80% while under treatment. Our last patient, Nityashri, had a forced expiratory volume of less than 80 while under treatment. And therefore, she could not be subjected to immunotherapy, because if she's subjected to immunotherapy, she might develop bronchial hyperresponsiveness and may go into anaphylaxis. While Jabin, she had a FE1 of more than 80% while under treatment, and therefore she was put subject to immunotherapy and she did well. There should not be any contraindications, such as the patient being on treatment beta blocker. There should not be underlying immune disease. You have to take into consideration the cost and the occupation of the candidate, and most important, the availability of standardized or high quality vaccines is very, very essential. Now, what are these high quality vaccines? You have the SCIT and the SLIT. The SCIT is the only approved route of administration in the United States. What happens in that? A weekly or bi-weekly extract of that allergen is given subcutaneously. Initially, it is given once or twice a week for a total period of 4 to 5 months. So in 4 to 5 months, the maximum dose is reached. or the maintenance dose is reached. Once the maintenance dose is reached, then the same dose is given every month for a total period of 3 years. While in SLIT, which is widely used and has been widely investigated in Europe since the late 80s, an extract of that allergen is placed under the tongue and the patient is asked to hold it for as long as possible, which could be around 1 to 1.5 minutes, and then swallow it. This is to be given at least twice to 3 times in a week. And for what is the duration? For as long as 3 years. So what are shared and different characters of SCIT and SLIT? They are effective for both. The shared characteristics effective for both allergic rhinoconjunctivitis and allergic asthma. Both have a disease-modifying activity. Prevention of development of asthma in patients with allergic rhinitis and vice versa. Prevention of development of new sensitivities in patients who are monosensitized. So if a patient is allergic to dust mites, tomorrow he can develop allergies to fungus. So it will prevent that. Prevention, persistence of benefit for several years after discontinuation. So once you have completed your treatment for 3 years, the benefit is for lifelong. What are the mechanism of action? For both is the same. It's a shift from Th2 to Th1 cytokine profile. What are different characteristics? Frequency and severity of systemic reaction favor SLIT. SLIT is unlikely, very less likely to develop any anaphylactic reactions. All you might develop is local reactions. While with SCIT, there's a big possibility that you can develop anaphylaxis. Defined effective and ineffective doses is favor SCIT. SCIT is definitely more effective as compared with SLIT. Proven effectiveness of multiple allergen extracts favors SCIT. Now, if you're allergic to only one particular allergen, say dust mites, then SLIT is good enough. But you're allergic to dust mites as well as pollen or fungi, then you might have to be given the injection, the SCIT. That brings us to the last point as to what is the take-home message. The concept of a unified airway to be considered in diagnosis. So you have 50% of your practice, you see respiratory cases. So in these respiratory cases, you should think of the unified airway, the problem starting from the ear, right up to the lungs. And in this, the allergy affection of the unified airway is very, very common. Only when you start looking for allergy, you will find that it is very common. It is prevalent in almost 20 to 25% of the patients. Manifestations of protein, that means they can change the form from time to time. You have seen these cases who presented with speech impairment, behavioral disturbances. You had a patient who presented with only headache earlier and subsequently came out with the symptoms of sneezing. So they can change the form from time to time. For example, they can present with just bad breath. So it is very essential that you should be able to pick up the underlying allergic rhinitis or the underlying allergies in these particular patients. It is always necessary to find the allergen. How do you find the allergen? And the single most important thing is with a good history. With a good history, you can really identify the particular type of allergen. Once you have brought it down to a dust mite or a particular type of pollen or fungi, then you do either skin prick test or the blood test, but it has to be done by the immunocap method, which is the latest and whose sensitivity, whose reliability is as much as the skin prick test. Environment control is very, very essential, because without good environmental control, 40% of the disease will remain there. So it is very essential that you identify the allergen and exercise environmental control. And always choose the right combinations. Avoid giving drugs in combinations and teach the right technique. Teaching the right technique to the patient is very, very essential. And therefore, you should make it a point that whenever the patient comes to you, he brings the devices with you. This is a small video clip I'd like to show you. The Hollywood clip. Please go through it.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Three things are very clear from this. Number one, using the wrong technique is universal. Number two, never ask the patient, are you using it correctly or not? Because every patient thinks he's very smart. They're always using the right technique. And the third and most essential thing is always make it a point to see to it that they bring the devices to your clinic and they show you exactly the way they're using it. And with this, I thank you all